Мы рады приветствовать вас в зале ПА.
Good morning. Today it's the second day of our assembly. This is the biggest event in the medical sphere. In our program we have more than 90 discussions and professional sessions. We have about 200 specialists from the whole world. The difference of this assembly is that in the program we have not only a session for specialists, but this year everybody can visit our forum. Before we start our next session, Ambulance Services and Emergency Medical Care Technologies for Efficiency, I would like to say that the assembly gives us an opportunity not only to discuss professional issues, not only to understand the medical sphere better, but within the framework of our assembly, we make conclusions of the annual festival, the Formula of Life, so-called. And this festival has been taken since 2012 among medical professionals. It gives an opportunity to share experience, to prove their professional qualification. Today, we'd like to give the award the Specialist of the Year, the Doctor of Ambulance Services and Emergency. And I would like now to invite a person for whom the medicine is not only an abstract term, but a very big part of life. This person here today is an honored moderator of our session, Chief Doctor of Ambulance Services and Emergency Medical Care of the Institute Bychkova, Professor Golunov Nikolai Filipovich. So please, Nikolai, could you say a couple of words? Dear colleagues, today, as yesterday, it will be quite an intensive day. And our section is called Ambulance Services and Emergency. It's very interesting, but we have a lot of foreign guests also who speak about a lot of interesting things. And of course, we should develop further to communicate with our colleagues, to study experience and to know what they are doing in this sphere of ambulance services and emergency medical care. So please be active, attentive. Today we discuss a very interesting issue linked with the development of technologies of ambulance services and emergency. Ambulance service is a complicated direction of the medicine. Some people say it's quite easier. You just dial a number and ambulance comes. So people think it's quite easy, but it's not like this. Because it needs also control, monitoring, benchmarking. We'll speak about it, quality control, a lot of other issues. So I wish you a fruitful day, colleagues. So now the nomination Doctor of Ambulance Services and Emergency Medical Care, and Selivanov Alexander is a winner in this nomination. Please go to the stage. Thank you very much. Dear colleagues, thank you for this unexpected award. I would like again to say thank you. Our service, emergency medical care, changed a lot within last years. I'm glad that I'm a participant of this organization. In this happy time for ambulance services, I wish myself not to stop and also not to stop working, developing, and also our services. Nikolai, Alexander, please take your seats. And now we start our session, Ambulance Services and Emergency Medical Care. I would like to give the floor our moderator. Thank you very much. Let us start. Let's colleagues start. Today our session will be very interesting, and we'll speak about technologies and about quality control. Also, some nosologic specialties of our work. We'll speak about blood circulation system, and also we'll speak about our prospects, what lies ahead. Please, let's start from the first presentation, and we start with what this ambulance service starts. Pavel Grigoriev, Senior Physician, Operations Department, Moscow Department of Health, will start this presentation. This is the format which we were the first to implement in our system. So please, Pavel, you're welcome to start. So each presentation should take about 10 minutes. Can I take the mic? Good morning. Yesterday at the plenary session, they were speaking about optimization, about breakthrough, which we all expect to happen. And of course, the ambulance service and also operative department is in compliance with all these expectations. Because we have to be in tune with realities and always optimize, streamline our processes. We should increase control, change direction in a flexible way, and also because sometimes we have many calls and sometimes less, so we have peak loads, and for us this is a challenge for our operative department. The spectre is also increased. The services, ambulance services, the range is increasing, and also the operative department. We also accept calls. And also we help people who don't have the cause for emergency. We help patients and say to them where they should go. Also, we have supervision services, and we always help patients if even we don't come to them. And the first aid can be also rendered by the other crews, and it helps us to optimize our processes. And what do we have today? We have logistics of incoming calls, and our operators operators should accept calls quickly and then switch these calls to other specialists. For example, we have some, inquiry information, and this is a separate department, and the operator should switch to this department. If we have colleagues, there are also free places. Please don't stand because there are so many vacant places. You can go on to and take them, and we'll continue. So if there are calls linked with some opinions regarding our services, also we have a certain specialist for this, but operator only processes calls and then refers them to some separate specialists, and we can process any number of calls with the help of these ways of cost control at the moment of its receiving. And we also split the process of calls processing when the respondent goes to the center. So here we understand whether this is life and death state. So then we ask questions about breath, trauma, and in this case, so we try to understand: is it here really danger to life or not? And then, if it's really dangerous, and we go. But if we decide it's not really so extremely dangerous, this call can be referred to a physician, and the physician has already filled information on the screen, and then a physician defines whether it's needed to send their ambulance crew or emergency crew. If there is no cause for this, in this case, a physician recommends what to do, and also if it's needed, he can help this potential patient to make an appointment. So we try to help people any way possible. And of course, speaking about the center of processing is quite important for us. First of all, this is a collection of statistic data. Also, we can see a number of calls, and also we can see where we have the most peak of this load of calls, and we can make already forecasts. Then we have multi-functional phones. You can see it's on the screen. We can use several lines at the same time, so the dispatcher can connect any specialist and give a competent answer to a respondent. And then so everything is written on the service part. One of the our specialty is that our system is integrated with our complex management system of the station. So the program manages the phone, so to say, and dispatcher, when he works at his working station, manages the phone and sends the calls in needed departments. What else did we optimize? We created a database. So the first meeting with an operator happens when he answers the phone, and we already try to define whether there was a call within this month. So we can see the information who calls us. This helps us a lot, because when we maybe have already filled some field information. In this case, we don't re-ask the same patient where he lives, his date of birth, because we already have this information, and it's automatic. We just need to correct some information to understand why we have this call now. And at the different stages of filling of this information, we again do identification of these patients to understand whether we already had this call, whether he already received our emergency crew or not. And in this case, we identify our patients several times, and we understand better what patient it is and what problems he has. We can see this in our already information. In this case, operator fills in the card quicker, and we can make routine much quicker, routine of the calls. Our Moscow discovery and our discovery, this is algorithm of dispatcher interviews, because we want to optimize answers and questions. For this, we have algorithms for all initial 60 causes. So in this case, we have different formats of calls. Here we exclude some human errors, and our solutions are optimized, and it depends on the situation. So we all have this in our algorithms. In this case, we can define whether it's really dangerous to life, or maybe just information is enough, and the emergency, the ambulance service should not go to patients. Physician can help him some other way. Speaking about routine, we can simplify the work of dispatcher, and we standardized all dialects practically, which can happen with the respondent, starting from welcoming words which are on the screen and ending up with all dialogues, practically all phrases. They are automated, and the dispatcher never invents anything, never rephrase all this. There are no ambiguous phrases. He just reads from the screen, and in this case, patients understands what will happen in the future. There are two ways. Emergency crew can come to a patient, or he will be referred to a physician, and physician will already help him with his problem. So you can see that operators don't invent, don't make up dialogues, and this is very important for us, and it happened during 2019. So we did not have any complaints for our service, and I think these are also accomplishments of this automation system. And these peak loads which happen in our operative department, so it needs. In this case, we always control our operators. We can see when they have breaks, who works. In this case, we can be flexible, and we can regulate their work. We can respond if there are peak calls, for example, which can happen during the shift. And also, we can forecast load depending on shifts which were before. And we understand when we have peak, of course, and in this case we have more operators, or maybe less calls, in this case less operators. So we try to avoid this waiting time. We do a lot of forecasting, and we plan load of operators, and this allows us always to respond quickly. And we also have quite ambitious plans. This is the system of speech analytics, when the conversation can be converted in the text. And in this case, it's easier to understand what person wants. Also, application of ambulance service, and all this will help us to improve quality even further. And I think this is quite essential. Thank you very much. Thank you very much, Pavel. This is quite an important part of our one center. Now we speak a lot about target technologies of medicine, and you can see how dispatch service works. Here we can analyze whether this is really significant call or dangerous for life and death or not, and we can categorize patients. Even if there are emergency calls, still they have different significance. Of course, we should respond quickly, but still algorithms of actions are important. We should distinguish what happens to a person, whether this is really dangerous for his life or not. Very often we are asked how can we come to patients so quickly? And one of this part of this quick coming, this is our organization of dispatching, and also the technology of interviews, categorizing, prioritizing, and program combination, the technology of inquiry, which helps us to fill in information quickly. And at all the stages, the first stage takes 3 minutes.
Of course, we are going to continue this effort. There have been a lot of interesting ideas about that. So we are going to delve more and more into innovative technologies so that our patients, the Moscow residents, could feel more comfortable while dealing with us, so that we could come quicker to our patients. Maybe there are some questions to the speaker. Okay, let us move on to our next speaker. We are going to speak about the possibilities of emergency medical care in terms of diagnosis. What can be done today and in future? Mr. Kadyshev, you have the floor. Good morning, dear colleagues. The subject of my presentation today is related to the emergency medical care. Could you please put on my presentation? In particular, we witness new state-of-the-art methods of diagnosis in emergency medical care. Colleagues, you can come. There are some free seats. You can take them. So I would like to say a couple of words about the modern diagnosis methods. As of today, the number of diagnosis methods in emergency medical care is increasing progressively. Today we are using the algorithm of emergency medical care provision. Here you can see some of the diagnosis equipment that we are using. All of them are related to our methods. These methods include pulse oximetry, electrocardiogram, it is ECG monitoring, glucometry, echoencephalography, otoscopy, thermometry and tonometry, which are conducted in 100% of cases. Of course, that's not all that we are doing. We analyzed our data for 2019, and here you can see the number of diagnostic manipulations that were conducted by the heads of stations. Here you can see what was done in order to establish diagnosis. The most widespread method of diagnosis include pulse oximetry, electrocardiogram, glucometry, cardio monitoring, otoscopy, echoencephaloscopy, that is used by neurosurgeons and neurologists. Ultrasound that is conducted, of course, first of all, in urology and in cardiovascular cases. I would like to trace our path over the last 4 years. We received an order of the Department of Healthcare, based on which we opened the Department of Child Stroke in the Morozov Children's Hospital. We introduced the screening scale for early diagnosis of children's stroke. Children's stroke is something that does exist, and we have a certain sample of children who were affected by this condition. We are conducting some research and practical efforts, the results of which are being published in media, in specialized medical literature, and in other sources. We have published 3 big articles in the VSC journals. This is what we are doing in terms of children's stroke. We are trying to optimize our methods and to find an algorithm that would allow to make screening or express diagnosis at pre-hospital stage. Another benchmark is 2014, where we did a lot of work in order to test a new methodology that included a cardio-BCG test. That methodology was approved by various medical centers. Our work triggered some interest in the medical community. First of all, among experts who are dealing with acute coronary syndrome without the increase of ST segment. This was particularly important at pre-hospital stage. We had quite a big sample of patients. And I also wanted to highlight now the year 2015, when we tested the mobile analyzer iStat. It allows to emergency medical care team to determine the gas composition of the blood and some biochemical parameters at pre-hospital stage during the diagnosis or early medical intervention stage. This has been tested, and we are already using these analyzers. We are still participating in active research so that this care could be provided with a high level of quality. We are also among the leaders in the development of new technologies, in particular regarding measles. There was an epidemic of measles, and throughout 2016 we did a lot of work in order to prepare our team to make the diagnosis. When we see some cutaneous eruptions of unclear etiology, we developed an algorithm so that medical professionals could follow this algorithm in order to identify whether it is about measles. I think that many of you have probably seen already this publication on our website. Of course, we prepared as a team to the issue regarding measles that we faced in 2017-2018. We are also continuing to develop some electronic atlases. We are including these materials in those atlases so that it is available for a larger community further. In 2018, we conducted another research. We were working upon the method of diagnosis of beta-hemolytical streptococcus of group A. When people face acute tonsillitis, we were following the directives that were published by the Russian government about the antibiotic resistance. Antibiotics should not be prescribed randomly. Sorry, I've had an issue with my microphone. So, of course, we conducted quite a wide research using the Express Streptococcus tests that allow to identify whether the tonsillitis is caused by group A Streptococcus. This was another important piece of research for us. Based on that, we developed an algorithm of diagnosis and tactics of care of acute tonsillitis based on the symptoms manifested by the patient. We had 252 patients that were included in our sample. The sample was quite representative, and the results are now used by our community. But then we moved on. In 2018, we introduced the method of direct otoscopy. We conducted a lot of theoretical and practical work before that, because the algorithms of emergency medical care and the clinical recommendations of emergency medical care were also reflected in the work that we were doing. And today the emergency medical care and ICU teams have otoscopes and they are now used quite widely. The results have been quite positive. We also published a manual together with a leading hospital in Russia. Together with their experts, we conducted this joint research, and we are continuing to do so. We are not dealing only with the bacterial agents. As of today, we see some promising prospects regarding the express testing on some viral infections such as flu. This year, fortunately, the situation with the flu is quite favorable. This is related to the vaccination campaign that took place in Moscow. Of course, winter has also been quite mild and the seasons have been shifted, but still, we are developing this express test based on immunochromatography method. It is a very quick test, and all the necessary parameters are being taken into account. I would also like to say a couple of words about the promising diagnosis methods that we are working on now. I am speaking now about the focused assessment sonography for trauma, as well as the creation of a consultant post that would be filled by an expert on ultrasound that could provide the necessary advice and help to identify the tactics and the pathology. Another area of research is what we call ITLS, or International Trauma Life Support. This is pre-hospital care in case of trauma. We are working with various state-of-the-art organizations such as Stroginot Technopark or Technopolis Moscow that is developing various early diagnosis methods at pre-hospital stage, so that a person could be placed in hospital on time only if it is necessary. We are going to move on in this area. Now all these priority developments and priority development areas have been identified in the professional community. We are working in this area and we will continue doing so. Thank you for your attention. Now I'm going to give the floor to the next speaker. Can you hear me well? Apparently not. So you can see that the emergency medical care service has a lot of opportunities in terms of diagnosis. Of course, it cannot be compared to a hospital that is provided with all the necessary equipment. Nevertheless, every year we are expanding the range of our opportunities. This year we are planning to provide ultrasound equipment to the emergency medical care teams, as well as feedback equipment that allows to exchange information. And of course, what's very promising as well is everything that is related to the use of express systems when the decision has to be taken quickly. We are going to continue using and researching into express test systems for diagnosis of beta hemolytic streptococcus, because it is related to the kind of treatment that will be selected. We have discussed it this year at the level of the Council of Federation Commission. Our experience has been quite appreciated, so we are going to continue developing in this area. Emergency medical care also incorporates the immediate medical care service, and we should think about their potential as well. Otoscopy has been mentioned by our speaker. Although we conducted research on it for quite a while already, it has been introduced in the routine practice quite recently, because it's not enough to provide otoscopes to the teams. Some training needs to be provided. It was done. Algorithms of the emergency and immediate medical care have been adjusted. So every novelty requires additional work so that this method could be used in an efficient way. Everything has to be operational, and the amounts of diagnosis that our speakers have talked about testify to the fact that this approach is working and helps our patients. Let us move on. We have been talking about targeting in case of cardiovascular diseases. So I'd like to give the floor to our chief cardiologist, Andrei Berezin. Good morning, dear colleagues. I would like to speak about acute coronary syndrome and its treatment in Moscow. First of all, I'd like to quote Professor Mikhail Ruda, who is talking about a close link between emergency medical care to patients with acute coronary syndrome and hospital care stage. He highlights the necessity to clearly understand the algorithms of medical care provision. That's what we have achieved now when providing emergency medical care in Moscow. Here you can see the slide that highlights the number of calls per day, the number of stations, posts, the number of experts that are providing this emergency medical care. We have specialized cardiological medical teams who help to provide medical advice not only at emergency medical care stage but also at hospital stage. So they help to diagnose the acute coronary syndrome in patients and, if necessary, transfer those patients to the specialized hospital quickly. We also have some regulatory framework in accordance with which the rights of providing emergency medical care in case of cardiovascular incidents are specified. So here you can see the share of cardiovascular diseases among all the calls to the emergency medical care service. It is 11.5%. 1.4% are patients with acute coronary syndrome. Here you can see the age breakdown of patients with acute coronary syndrome. As we can see, 1/3 of patients are people of working age from 40 to 60 years of age.
По месту вызова обращения к пациенту с острым коронарным синдромом это, конечно же, выезды на квартиру.
Most often, emergency medical care teams go to patients with acute coronary syndrome at home or in polyclinic.
Оказывается помощь общепрофильными бригадами и общепрофильными врачебными бригадами.
Most often, there are general practitioners and paramedics who come to such calls. And if a case is particularly severe, there are specialized cardiovascular emergency medical care teams that go to such calls in about 4% of cases. In case of acute coronary syndrome, there are 15% of patients with increase of ST segment, and the remaining 85% are patients with acute coronary syndrome with the increase of ST segment. Here you can see the scheme of registering and responding to a call. There is a first-hand analysis that is conducted during the first call. If possible, there is a remote consilium with a doctor of cardiological team or a remote consilium with emergency medical care station doctor who helps to take a correct decision regarding that particular patient.
And he can do medical evacuation, or if still the status moderate, a patient can stay at his place, but with monitoring and maybe a dynamic control from physicians at clinics. Then we have the causes. This is pain in chest, and we define what crew, emergency crew, should go to this patient. On the slide you can see the algorithms of our choice of emergency crew, and operator usually decides what crew to send to this or that patient, and it depends on patient location. So you can see here that operator in online mode can see all crews which already help patients or free emergency crews, and he can quickly choose a crew for a particular patient. Now you can see the operative indicators. They are at the high level, and in accordance with the clinical recommendations, patients can go to medical health centers as soon as possible in order to get first aid. This is a revascularization of myocard to restore blood circulation of damaged arteries. And here on this slide you can see changes which are included in the algorithms of service rendered for patients with acute coronary syndrome after clinical recommendations issue. So this is from 2015 with increase of ST segment and without increase of ST segment. We can here have prescriptions, for example, not extra oxygen support, and also pain removal. And we can see the algorithms when patients cannot be sent to hospitals within 90 minutes. In this case we can conduct some first aid procedures for patients, but very often so you can see here the acute coronary syndrome without increase of ST. In this case, anti-aggregate therapy can be conducted, monotherapy by acetyl acid. And if it's needed, paramedic crews can also make diagnostics, so they can do ECG in any place of Moscow, and they can remotely send ECG data. Now ECG data is converted into digital format. In this case, we can make processing quicker. So physicians also, make diagnosis quite quickly with having this data. Here you can see the example of feedback when on the tablet. So the encoding of ECG data comes, and it allows the emergency crew to render professional care. Also, we can conduct a remote consilium with other cardiologists. During 24 hours, we have more than 2,500 ECG. Then they are analyzed by physicians, and here we can see the dynamics of detection of acute coronary syndrome without ST segment increase. You can see it stays high. And you can see infarction network of Moscow city and also the hospitals which can render these services. Also online mode we have 24/7. Online service works 24/7. Then hospital choice. So it depends on location of patients, but the main condition is free places in hospitals and location of hospitals. For this, we have IE hospital program, and you can see here information tableau, and operator has this data, and on this screen you can see free vacant places in hospitals, and then so the information, so we have whether this is busy, some places are busy, and in which hospital. Thank you very much for your attention. Thank you very much, Andrei. Yes, I can see you have conducted enormous work, and this project of infarction network got Mayor Premium. The outcome of this work of ambulance service and emergency service so led to a decline of mortality by twice in the area of myocardial infarction, and today we have 6.5% of decline of hospital mortality. These are European indicators, and within a short period of time we could reach these figures through clear algorithms of service rendering. Some people say that medicine is art, but art is to help people, and if we want to help people, we need to be in compliance with algorithms. And for today, it's not enough to get patients to profile hospitals. Also, for example, some equipment is important, and in 100% in Moscow it happens. This is also the accomplishment of our joint work. So patients sent to necessary hospitals, and Hospitals know when that they will receive some patients, and cardio emergency service also knows about this. So everybody, even surgery rooms also are ready for this. We try to minimize time of wait. This time shortened. We don't need a long-term investigation, examination of patients. We try to understand quickly how to help our patients. And also here we have also some way to go. We'll also implement cardio tests in some complicated cases. And also one more thing. So this is the second opinion. Now it's very fashionable to say second opinions, and today at our station we implemented also this remote consilium, and cardiologist, psychologist, pediatric personnel. So it's the support of colleagues to make decisions, and today we have not only interpretation of diagrams, and speaking about the time, in analog mode it took 20-15 minutes, but now it takes 3, 4, 5 minutes to analyze these diagrams. And sometimes we can conduct remote consiliums and also correct medication treatments in some complicated cases. And this technology will be also distributed to other nosologic formats which need targeted approach. Let's continue, and let's go from technology to quality control. And I would like to give the floor to Mr. Hisanov, please. You are welcome. Good afternoon, colleagues. Today I would like to speak about benchmarking, and this benchmarking now is in our work everywhere. What is benchmarking? Benchmarking is one of the most important directions of strategically oriented continuous processes of improving organization activities based on benchmarking experience. What does it mean? Target goals are chosen, and we make efforts to achieve them. So let's look at the system, how it works before benchmarking, system implementation, and after. You can see here some options of approaches. When we implement benchmarking system, we evaluate ourselves, not thinking about ourselves that everything is good, but how we can improve our processes. Also, there are main 5 types of benchmarking: internal benchmarking, and some types of external benchmarking. This is competitive benchmarking, also so inside of the industry benchmarking, outside of the industry, and external benchmarking. But each organization should develop its own individual benchmarking, and should analyze all options of benchmarking. Now you can see here the component of external benchmarking. So last year we conducted the research. Pricewaterhouse company, research company, conducted this, and we had the analysis of efficiency of ambulance service in metropolises of the world. Moscow ambulance service proved to be the most efficient among emergency services of metropolises of the world. So only Berlin, London, and Paris emergency services proved to be better than Moscow emergency service. To the right, you can see the conclusions of this research. And Moscow emergency service regarding some indicators proved to be the best, but some indicators proved to be worse, and we took the second, third places, but we can define our further directions to become leaders in the world. Speaking about internal benchmarking now, I will I would like to be here more more specific, because for us it's quite important. Internal benchmarking means screening of the organization itself to understand whether the department and branches of this organization work well, and to define the best. And the other should also look at them, how they work, and follow their examples. Internal benchmarking usually doesn't need any investments, sufficient investments. So we need to have also quality control of medical aid, and for this quality control, internal benchmarking is very good. What types of internal benchmarking is used at our emergency service of Puchkov? So first of all, the quality of all parameters supervision, especially for patients with so different traumas and traumas, acute coronary segment and so on, syndrome. Then a remote control of diagnostic events, where the algorithms were met, and also target goals, whether they were achieved or not. So on this slide, you can see the extraction from the system. This is the monitoring of calls for car crash events. Here you can see the main joint indicators, time of arrival to patients, and then getting patients to hospitals. And here all indicators can be distributed to some particular calls, and if somewhere we don't achieve target indicators, we should understand what the reason was. Thanks to this benchmarking system and time control, we managed to shorten, to shorten the time of stay of doctors. So our time now, you can see, shortened by 4 minutes. On this slide, you can see the example of the report on quality control structural department. The first phase of quality control, the first level, which happens in the departments themselves, and also the control of the second level, which can be done by deputies of chief doctor in regional departments. Now the results of quality control, the dynamics can be seen on this slide. The evaluation of quality coefficient during 3 years becomes higher and goes and soon it will get 1. In the system of electronic benchmarking, quality control, some main directions are included. So diagnostic diagnostics in compliance with approved algorithms. This acute coronary syndrome, pulmonary thrombolia, and also brain traumas. In the benchmarking system also we include monitoring of mortality rate during the emergency crew stay and also time parameters of crew stays. How does it all work? Help should be given in accordance with approved algorithms after the visit. All manipulations, diagnostics, the result of the call and emergency activities are filled in the card of call, and then this information is automated. You can see the example pneumonia patient, and on the bottom you can see different activities, manipulations which were made by the crew. This information gets to the database, and then when we do screening, monitoring of this patient, pneumonia patient, we can see this information. Here you can see all manipulations done by doctors, and also we can see some defect cases in which not full volume was done.
So if we take 2019, when we had this system operational for all the diseases, then the overall rate of diagnostic activities for all the diseases that I mentioned earlier reached 98.4%. There are some compound criteria of assessment of the work of station of emergency medical care. There is a number of criteria used, including qualitative and quantitative criteria that reflect various aspects of work. For example, the time, quality of work, the presence of justified and unjustified calls, the staff turnover, and number of other criteria. After the overall calculation of those criteria, the final ranking of units is done. Here you can see an example of such a quarterly ranking. In the middle you can see the medium performance of the station. Then you can also see stations with a maximum compound ranking, and to the left and to the right you can see stations with a minimum compound ranking. The structural divisions having the maximum ranking are highlighted, and those who are lagging behind have to aspire to reach the performances of the leading stations. To do that, they need to perform some organizational and streamlining activities. What are the other areas of use of the benchmarking technologies that could be used in future? We could include all the diseases into the system of electronic benchmarking so that we could assess the necessary diagnostic manipulations provided for in the algorithms. Another area of development is dynamic assessment of the key operational performances of emergency teams. Another area is the expansion of the number of criteria of compound assessment of the unit's performance. And the fourth area is the use of benchmarking as one of the tools of the quality management system in order to get JCI certification. Thank you. Thank you, Artyom. Indeed, this is a very relevant subject. And it's very difficult to build the quality control system for emergency medical care. In contrast to a hospital, we are not working in medical organizations. The teams are working remotely out of the hospital, and those who perform quality control cannot speak directly to the patient and cannot check the work of the emergency medical care teams on the side. That is why electronic technologies have to be used. However, such a quality control system has two aspects. The first aspect is internal control that was mentioned by Artyom, and another aspect is the openness of the medical organization and taking into account the opinion of the patients. This is crucial as well, because if we don't know what the patients think about us, how they assess our work, the internal control will not be complete and correct regarding the assessment of the medical care quality. That is why we have some state-of-the-art technologies here. For example, every day our system sends SMS messages to 300 people to get feedback from them. We ask them 5 questions about the quality of medical care provided. So this is one type of feedback analysis. And as of today, so far we don't have any questionnaire of assessing the quality of emergency medical care team operations. We do have such questionnaires for hospitals, but not for emergency care services. We have already developed such a questionnaire, and we have published it on the website of Emergency Medical Care Service. And regularly we do analyze the data that we get as feedback from our patients who fill in that questionnaire. So this is another mandatory element in assessing the quality of medical care of a medical organization. And of course, speaking about the quality of medical care, we should absolutely take into account the professional competence. The professionalism matters, the knowledge of the subject matter, the skills allowing to work quickly are among the most crucial ones for the medical care in emergency conditions. So this is one of the most important aspects. The question is how to organize all that, especially in a big system. Andrei Kolasik is going to speak about that. Thank you very much. Good morning, dear colleagues. I will speak about technologies of training in a medical organization. We are going to speak, of course, about the technologies that are being used by our organization, that is to say, emergency medical care station. Here we need to answer the question, what is preferred? If we had a talk show and the possibility to ask you a question and get your answers, I think that the changes in the training system of our employees are different, but I guess everyone would prefer electronic systems. I would like to start my presentation with a quote. It's a Chinese saying, "Tell me and I will forget, show me and I will perhaps remember, but involve me and I will understand." End of quote. It's all about learning. Of course, we can also use our Russian and Soviet sayings such as learning is light, not learning is darkness. But we are speaking here about technologies of training and learning. So what are these technologies? If we had here colleagues from the Department of Education, perhaps they would criticize me, because the classification of technologies of training is quite complicated, and perhaps the medical staff will not need all of these technologies. That is why the training technologies that we are using or that we are planning to implement in the nearest future include quite simple types. There are some traditional educational technologies. These are the technologies that we are most used to. I am now referring to the people who got their education back in Soviet times. Recently, however, remote educational technologies are developing more and more actively. They can have various types, but let us just call them remote educational technologies. There are also some simulation methods of learning. We are quite used to them over the last 5 years, and we understand that contemporary learning without simulation technologies is just impossible. Although, if we remember how those technologies were implemented, we can say that at the beginning they were quite controversial. But now, as we witness changes in the society around us, we understand that we cannot develop without simulation technologies. Now, there are also project technologies. These are the technologies that allow to develop professional competencies. This is basically what we would like to implement. There are also case technologies, or learning on problems. And the last point is self-education. If we consider contemporary educational issues from the point of view of the changes that are taking place, it's better to just accept it than to continuously reject it. I'm now referring to self-education. The role of teacher today is changing. Self-education is anyway key. It has always been key. The teacher should not force students to learn something. He should just direct them. So ideally, we would like to reach this level of self-consciousness on behalf of the students. Now we are also switching to the accreditation of all the medical specialists, and this accreditation is a certain pass that allows people to start practicing, and all the educational methodologies are based on the accreditation requirements. We are making an accent on competencies necessary in the professional. We are also using professional standards that we have to respect. Another particularity of contemporary medical education is the increase of the number of medical organizations who get a medical license and are going to offer some educational programs. So when we are speaking about our goal, we have to take all that into account. Our station pays a lot of attention to continuous learning, and we need to bring together educational technologies, all of them, so that we can achieve the goals of training. It is a targeted, focused approach, and we do already have some background to really target our education. Our goal is to make sure that the trainer, the teacher, or the mentor just plays a role of a corrector and a follower. What are the technologies that we are already using at our station? Of course, we are using some traditional educational technologies. Of course, we are very used to having direct contact between the students and the teacher. Yes, we do prefer that, but no one is abandoning these technologies now. The particularity of medical education is that we have to also use some remote educational technologies. Part of our colleagues that participate in continuous medical education are aware of the website edu.rosminstraf.ru. There are some educational platforms there where one can learn, and the overwhelming majority of our employees who participate in this continuous education 2.0 use educational platforms that are developing quite actively right now. This environment has already been shaped, and in the nearest future it will just be filled by educational content. Of course, we should also mention the efficiency of remote educational technologies. When we are speaking about electronic resources, everything seems to be quite simple. It is quite easy to watch some statistics. To see some statistics, it will take just 5 minutes. And we need to upgrade the existing educational technologies to keep up with the time. Here you can see data for this second half a year of the last year. Are these figures good or bad? This is subject to a discussion. By the way, if you want to continue this discussion, we can continue this dialogue on the station of on the stand of our station. Now, simulation education. It is an integral part of training for our doctors and medical professionals. Usually the leadership does a lot to have all the necessary equipment for simulation activities. Here you can see a graph that just shows the shares of every kind of education in the overall coverage. The particularity of our organization that has been mentioned is the number of staff, the different level of competencies, the different level of initial education, the constant changes that we face, the constant changes in the regulatory framework that we have to deal with. So if we consider these shares of various kinds of education in the overall scope, we can see that traditional education in form of lectures has the smallest share. It is related to the particularities of work of our stations. Now, simulation training has a bigger share because there is the possibility of self-education, there is the possibility to try and test various systems. We have the mentorship system where we are using the simulation, and we have tutors who select a particular substation and provide training there. The biggest share is that of electronic education, since it allows us to cover a larger territory. What will be the outcome of all that? It does create some prospects of learning at the station. The medical organization that provides training of medical staff needs to have the wide spectrum of educational technologies. We need to master all the educational technologies available, not just to be competitive and interesting for our trainees, but also to be able to compete. Because the continual medical education system shows that our people can choose where to learn. And another important conclusion is that the medical organization needs to combine educational technologies, mix them. We are not saying that the use of electronic educational resources will replace the other forms of education completely. No, we are speaking about a mix of various educational technologies. We are working on that and we are developing precisely that. The mix of technologies to reach an optimal trajectory of learning. Thank you. Thank you very much, Andrei. As you mentioned, at our stand there is a special panel where one can have a look at our electronic educational resources, and there are experts there that will be happy to answer the questions. We are nearing the end of our session. Let us sum up. Regarding the educational resource, if you paid attention during this forum, many speakers are using the 2.0 abbreviation. For example, patient 2.0. What's a patient 2.0? That's a patient that requires a different approach, not a paternalist approach, but a partner approach. And a lot of attention is being paid to that in the world. Regarding our educational technologies, we can say that in 2020 we are going to switch to this education 2.0 approach. We are going to switch to the electronic platform for continuous education. Last year we created this portal and filled this portal with content. This year the portal will be further developed. There will be more and more opportunities for self-education since the platform will be filled with educational content. And we are also reflecting upon the way this portal could be transformed into an electronic medical library. That's also an interesting project for us. The website users should have all the opportunities to increase their professional level. Some other interesting areas we are planning to develop include the following. Of course, our profession is inseparable from practice. We are now finalizing the development of new formats. All the employees of the station can take part in this project. We are going to have a particular training on difficult diagnosis or severe diagnosis, as well as cases from practice. We are going to consider there the interesting cases, the cases of complex diagnosis, the cases of saving that will be described by our colleagues, and that will represent a wealth of educational material. Thank you, dear colleagues. I hope that it has been interesting. We have covered all the aspects of our activities, and when we were speaking about those technologies today, we were actually speaking about our plans for further years. I wish you good luck and have a nice day.